Got it. So welcome everybody. This is, I think it's episode 26 or so of AB1400 CalCare office hours. Has been a joint production of we're getting feedback there because
sorry about that.
No, but it's a joint production of Healthcare for All Los Angeles and PNHP Southern California. This weekly meeting has been happening every week in a row for, I think it's 26 weeks, from 5 to 7 p.m. and will continue. And the meetings are about a bill that's in front of the California legislature, which is AB 1400, which would do a single payer universal healthcare system here in California. And the purpose then of office hours is to share knowledge about our healthcare system, which has problems, this bill, which we think is a good solution to those problems, and to answer questions that anybody out there may have. So I usually still like us to give people a few minutes at the beginning to join. And so maybe we'll launch into the intro kind of overview of the bill a little bit in just a few more minutes. That's okay. Super. Nice to see everybody. I'm gonna get something to drink, but welcome if you're joining us. I'll be back in 15 seconds. 15 seconds.
Make it something interesting.
Welcome, Dr. Bill.
Hey, thanks. Happy to be here.
I got to make you a co-host too, so you can share. There we go. You're a co-host.
Paul, do you have a number of people who join by Facebook?
Yeah. It's both.
How much is it usually?
I don't know. I don't know. It varies. It can be like 25 to 30, sometimes 100.
Really?
Yeah, we really get a huge crowd.
It echoes.
Mm-hmm.
Yeah. Don't they send reports like how many views and stuff like that? So
I guess.
Because it's not static. The views can occur over time, right?
Right. But I think also that it can, and I think if you're looking at the Facebook page that's hosting it, I think you can see how many are on at any moment.
Apparently there's 5 people just starting to come in.
Okay.
And more to come.
Welcome everybody who's joining us. This is AB 1400 office hours, CalCare office hours. We will be talking about the single payer bill that's up in front of the California legislature. And ooh, look at that. Continuing with our Star Wars theme. And we'll, at 5:05, we'll launch into the intro. Just welcome everybody who's joined us here in Zoom, and welcome people who are joining on Facebook. Both are places where people can ask questions, and that's what this is mostly about, is asking questions and answering them.
Usually, Ron, we go over the file that on CalCare that shows the different.
Yeah, I got one. I'll hit that at 5:05.
Sure.
But I have it sort of queued up in my share screen thing, so should be okay. And I'll go over that one unless somebody else does. You know, I have been actually away from office hours for several weeks. My mom fell and broke her hip. It's been a big ordeal, and obviously every time you have stuff like this happen in your family, you get a new set of exposures to the healthcare system and its discontents and the things about it which makes discontents. So I've had some of those. but we'll, and so one thing too, I hope we get lots of questions, and hope lots of people want to, who are, especially people who are most up to date on recent developments, will answer some, because I'll be catching up. So let me,
Gina Harris, our esteemed colleague in these town halls, has done a tremendous job presenting those the CalCare principles and all of that in your absence. I'm not sure how anyone could fill the, you know, the big shoes that, or shoe prints that you leave when you're not with us, but Gina has taken that on and done a great job.
and she's with her mom this weekend, but she's spectacular, and I know everybody, or almost everybody here, has been a regular, and I appreciate everybody continuing and joining in and answering questions. But okay, so let me share the screen, and we'll go. These are the basic elements of CalCare. So and also then again, for anybody who has just joined us, welcome. This is AB1400 CalCare office hours. Office hours is an every Sunday 5 to 7 p.m. session that's mostly aimed at answering questions about a new single payer bill that's up in front of the California legislature. The act, when passed, will be called the California Guaranteed Healthcare for All Act, but the program that it will create is CalCare. And so then, just by way of introduction to hopefully get the juices flowing for questions and that kind of thing, I wanted to talk about what CalCare is, or what it would be when implemented. So the first thing is that it is a program of universal coverage, and that means everybody in and nobody out. And that's in distinction to our current healthcare system, which leaves tons of people out and leaves a lot of people out partway out. And so this would say, no, the only eligibility criteria is that you live here in California, and it doesn't matter your immigration status or really anything else. You just have to be here. And that simplifies a topic, which is determinations of eligibility at points of service. If the answer is yes to everybody, well, that's simpler. And so the next thing is that it's a single payer plan, or a single payer public program. So what does that mean? So right now we have a system of multiple payers or insurers, and some are in the public sector and lots are in the private sector, and lots of people don't have any access to any of those things. And that's actually a big source of inefficiency in our system, and in fact drives up costs in a lot of different ways. And so this would say, no, the better way to organize something like that is to, instead of having a multiplicity of insurers and payers, is to have one insurance company, if you will, and that company is all of us. It's the public. And so it'd be the, administered by the state of California, but it would be a single payer, single public program. And it would give full and comprehensive benefits. And so that's important because lots of our current health insurance products that are out there give incomplete benefits. And that leaves people who need care, who have something called insurance, not having care. And, at some point, maybe we'll be able to talk about, well, can you do that? Can you fund everybody and give everybody very comprehensive benefits? And the answer is yes. And there's lots of good examples of that all over the world. But that's what this program would do. And then another thing that it would do is that it would give people, it would be freeing to people. And one thing it would do is give people a maximal type of choice. And that's the choice of where you go to get your healthcare. And that's a good thing. People want that. In our current system, people are burdened by big barriers to choice because the multiplicity of payers each has their own network. And so there are people who are in network and out of network and sort of in network, and you can't go wherever you want to go. In the case of CalCare, we would be putting, for all intents and purposes, all major providers of healthcare would be in network, and all offices, with very, very, very few exceptions, so that essentially people could go wherever they wanted to go to get healthcare. And then another important barrier that would be knocked out completely by CalCare is the barrier that's created by people having to come up with money somehow whenever they need to get healthcare, which is a huge barrier. And those come in a bunch of different ways. So they come in high deductibles, which are relentlessly increasing, co-payments, and some other structures. And of course, people also have to just pay premiums, or employers have to pay premiums, and all that would go away. And we would switch to a system that's free at the point of service. You have a card that says you're in CalCare, and you just go, that's it. And then, this is a big change, would be a big, big change for the state of California. And it would change a lot of what work is in the healthcare industry. And in particular, because you're stopping having kind of all these multiple insurance companies, and then also the huge, what I call billing industrial complex, all of the people whose work is to send bills to different insurers and figure out which insurer to send it to and what form and what, online portal to get on and how to resolve problems. There'd just be one place. And so that simplifies a lot. And that simplification is a source of savings, but it also means that certain types of jobs would go away. But this bill, which was written primarily in the policy shop of the California Nurses Association, and we're incredibly grateful for the leadership of the CNA, which is a union, the biggest union of nurses in California. They wrote this, and they care about workers. They are workers, they're a union. And so as part of that caring, they have included in the bill what's called, the framework for what's called a just transition, so that people who their work is displaced by these big changes are able to get retraining or extended unemployment benefits, priority for state jobs, a set of possible things that will kind of cushion and help transition as we transition the system. And finally, that the type of care that's would be given under this system is care that's based on patient need. And the bill specifically forbids kind of programs of incentives that are like capitation type incentives, or so it's incentives to restrict care, or well-intentioned or not so well-intentioned value-based schema, but many of which have mostly been found to be just kind of like fancy efforts to restrict care or make care more profitable by not doing certain things or doing certain other things, and instead would just pay for it. And that's, so be patient care based on patient. So that's in outline form, the major features of what CalCare would be. And so, it's at this point, having given that introduction, and then want to welcome anybody who's shown up in the time of this introduction, that we just open things up for questions or thoughts of anybody who's either here in Zoom land, or if anybody's out there in Facebook. And maybe when Paul comes back, he can help us. Oh, I see a thing. Let's see. So I see a question that's in the chat. And as I mentioned before, and so this is a question that from J. Gideon Sarantinos. as I say, a stalwart of the effort to get single payer in the state of California, an Angelino. Jim asks, do we have any updates on new funding mechanisms to fill the gap after Medicare, et cetera, are consolidated into CalCare? So let me put that question out for others who are here with me to see if they have any updates on any of this stuff, or anybody here want to, because one thing is, because I've been a little bit out of the picture for the last several weeks, I haven't heard anything, but at least I can, is anybody with a hand up? No. So maybe there's no updates, but I can at least give maybe some context to the question. And the question is this, which is, if you go to a single payer system in the state of California, then that means that the current money that's spent in California has to be collected into one fund. That would be the CalCare Trust Fund, to be dispersed for care. And so what would be the sources of money for that? So it'd be a lot of the existing sources, and that includes collecting money from federal sources. So the federal government spends a lot on healthcare in California and in every state. That would happen through a application for federal waivers process. Then there would be the collecting of all the current state spending on healthcare. And then that still would anticipate a gap of money that needs to be raised through taxes. Now, it's important to make the point that while there will need to be some kind of new taxes to fill that gap, those taxes are in lieu of all the money that's spent out of individuals and organizations, including businesses, pockets all over the state, the net of which is predicted to be savings for all those people. But it still requires plans. So I see Dr. Bill's hand raised. Do you want to pick that thread up, please, Dr. Bill?
Sure. Thanks. So, I was waiting to see what you might not cover, but you covered most of it by far, and that is, what is the overall kind of like revenue gap in general. So what are the revenues that we have to pay for the program? If that's a revenue gap. Then the other thing would be like a time gap to collect those revenues. So over what time period would it take then to collect those revenues? So that's another consideration. How much time will it take? People talk about phasing in the program, and how much time will it take to generate those revenues that it'll take, both to collect from the federal government as well as to collect it in the form of taxes that replace health insurance premiums that we all pay now through a commercial insurance. So I think you covered the revenue gap, like, kind of an accounting sheet type thing. In terms of the time gap, the bill, my understanding, and you can correct me here if I'm wrong, Ron, is that the bill states specifically that none of the costs will be incurred until the revenues are basically there to start to fund the program. So that I think is a very important point as well, is that however those funds the revenues are collected, none of the benefits happen until the funds are there, and the specific mechanisms have not been specified yet. That will come with more legislation and or in the committee hearing process where amendments are added to the bill.
Yeah, that squares with my understanding, and my recollection is that time gap that that you talked about is determined, or that it's the bill specifies that the Secretary of Health and Human Services has to kind of certify that all the revenues are in place. So that in fact, that time gap is like a baseball time gap, not a basketball time gap, where you have to have three outs in the inning. In this case, it's that the Secretary of Health and Human Services says all of the revenue sources are in place, so that nobody has to sort of worry like, oh, well, we can't pass this without all that the order doesn't have to, the trigger isn't pulled on spending until all the money is in place. And so nobody has to worry about the problem of that problem, because the bill specifies that's not a problem. And then, so I also see that there was a question before that. It's just where the chat had scrolled down to, which is from Chris Shimiso. And I assume Chris is out there also in Facebook land. So greetings, Chris. Thank you for submitting your question. And that question is, how long would a person have to live in California to be considered a resident? And so it's a super question, because since every resident of the state is covered, well, the question is, well, can you just roll in on, the midnight train to San Francisco and start getting healthcare the next day? And so it's been, let me be honest with you, it's been a little while since I looked at this part of the bill, but my recollection, but somebody correct me here if I'm wrong, is that the bill said that the left the residency, didn't specify a time frame, because it left the residency definition to the state's definition of residence. And so somebody correct me if I got that wrong.
No, I think you're right. And it said that proof of residency is required. So how then does the state prove residency, or what proof generally is required by the state for residency? Usually it requires a utility bill, or something like that shows that you are a resident. That I think that was the extent of the specification. I don't think there is a time period specified. It's just proof of residence.
Yeah. That's also my recollection. But I also think that there was a thing in there, again, it's been a little while since my deepest read, that also said that there's sort of, especially in emergency settings, a presumption of you're a resident, and not a presumption that you are not a resident. So, okay, so then let's see. I see more, another question from Jim, also on Facebook.
Hey, Ron.
Yeah.
So I'm going to post in the chat right now the link for the bill text, and it has the bill text and other information. So those who are not, who can't see that, I don't know if we can copy that and paste it in whoever's monitoring Facebook. But it's the website is leginfo.legislature.ca.gov. Leginfo, like legislation info, leginfo.legislature.ca.gov. And that you can find the bill text and other information about AB 1400 there.
Got it. Thank you. And yes, so that, and in general, also that can often be searched by, you can often put text and search for things in there. So that can also help people kind of directly answer some of their own questions. So on to another question. So this is one that Jim Sarentinos had posted. So he said, how would concierge services be funded by CalCare, given that customers pay a monthly fee for all the healthcare they want? It's the all-you-can-eat version of healthcare. So the short answer to that is that that type of healthcare would not be done within the program. So first of all, everybody who's in CalCare can already has comprehensive benefits that they can take essentially everywhere. So, but maybe what he's asking about is people who opt out, like providers, because the bill says that providers have to sign in like individual providers. So maybe it's thinking about like a kind of boutique-y internal medicine practice in some ritzy part of town that's used to doing concierge medicine under the current arrangements. And what that usually is people paying like a cash subscription to be able to get a certain amount of access to a primary care doctor. And then that primary care doctor generally is understood or to limit their panel of patients so they can be very hyper responsive to often pretty wealthy people. And but those are not usually like insurance programs in the sense that they then pay for things like laboratory studies or medications or hospitalizations or anything like that. They're kind of like a pay to have one doctor be available to you. But at least my understanding of the bill is if that doctor was a CalCare provider, then like they couldn't do that. They couldn't take payments for healthcare services that are covered services under the program sort of separately and from a different source other than just from the state trust fund. Now, if they did say, well, I want to do that, I want to have this kind of concierge practice, then the bill says that they have to sign they have to sign an affidavit if they do that they've done that, and then they exclude themselves for 2 years from taking any money from the state program. And that makes it so that only not a lot of people can really do that in big numbers. So while I suspect that there would be a tiny number of people out there who would do that, I don't think it would be a big factor in the healthcare system. That's my sense of that one. Let's see. So, and anybody with any thoughts or questions about that, or would be like a follow-up to that or a comment?
With all due respect, Ron, I think there's an awful lot of concierge medicine going on. And I think
right now, but I don't think there would be a lot under the system. You think there would be?
I think there will be. And that's one of my big concerns.
Well, so one of the things is that you become limited to the number of people who can do that, who have the money to afford to pay for that kind of thing, which I think has tended to be a lot of money, although I haven't recently checked. So that may be the question. If it was somehow very affordable, then you're right. It could.
I think on the west side of LA, there's a lot of people in that category. And
San
Francisco.
Well, there are certainly wealthy people in our state, no question. But the question is would that significantly carve away some big number of primary care doctors from the general pool? And you may be right. I mean, I think that it should be more of a concern. I think there are more questions, but I will stay on this topic till we're not on this topic. In fact, I think I saw, was it Isaac's hand that was up? No? Was that a follow-up on this topic, Isaac, or another question?
Oh, yeah, it was just going to be a follow-up, but do we have any idea why the authors of the bill decided to leave that carve-out available rather than be more restrictive and require all practicing licensed physicians to take CalCare and not be able to do that concierge stuff?
Well, I mean, it's hard to, I guess, I should say the short answer. My short answer would be, I don't know, but I could speculate, and my speculation would be that they maybe think that the like at some level that the right of people to enter into private contracts still matters, something like that. So it may represent either a reading of other law or a belief. But I do also think that the way that it's structured in the bill, I believe, is somewhat like the way Canada does it too. Where in Canada, you are allowed, like people, there is a world in Canada where you can just be outside the system. What you can't be is like in England, where you're inside and outside the system. So I think at least they were looking at that model, and that this is emblematic of that model. But whether there is some more, what do you think? Like, what do you think? Why do you think it's in there?
I think maybe you're right. Maybe they feel like it would be difficult to structure the legislation in a way that would provide for that. But it strikes me that you get a license to practice, and you have to be licensed to practice. I don't see why you would not be able to say, if you're licensed to practice medicine in the U.S., you cannot do it. You cannot do it in a way that undermines the health of the country. And it strikes me that multi-tiered systems allowing U.S. senators or multimillionaires to go outside the healthcare provision system for everybody else in the country does undermine the health of everybody in the country. So it would strike me that that would be a better approach to it. But I don't know. I mean, it sounds like from what you just said that Canada and England both have some type of way to go outside of the healthcare, like the national healthcare system.
Oh, well, England has a gaping hole, which is like, in fact, a whole world of two tiers created by the fact that an individual provider can both see people through the NHS and have their own private practice or consultancy. Dr. Bill, I see your hand up.
I'm chomping at the bit for this question, but I mean, you might want to be asking, say the bill author, a person like Carmen Comsky or Michael Leidy, or someone who's really a policy wonk about this. But I think that the idea is the difference between a single payer versus a national health program like the National Health Service in Britain. So when you have a national health service, how do you give people an alternative to the National Health Service? They actually offer private, commercial health insurance for people. And guess what? Most people by far use the National Health Service. With a single payer system, you outlaw all other forms of insurance. So there is no insurance anymore, but you still have practitioners can still practice. There's no insurance to cover those practices. So I think that's true of single payer systems in general. And unlike Nancy, I'm not as worried that there's going to be a significantly huge number of people flocking to concierge services, pay for cash services. Yes, there's extremely wealthy people. Yes, they will pay, exorbitant prices for things and cash even, because it's actually not out of their own pockets. It could be a corporate credit card. It could be a foundation like they're paying now. But guess what? Even corporations and foundations don't want to spend money on things they don't have to. So if the single payer system is working like it does in Canada, very few people are going to seek medical care that's outside of the single payer system. And that is the case in Canada. Very few people use those, those pay for cash services because the single payer system covers all essential medical services. So why would you go outside of that? And I think Michael Moore actually made that point very well in his movie Sicko when he was interviewing people in Canada, who said the same thing. Conservatives, people who would be called Republicans here, said, why would I pay cash and, buy healthcare on my own, because it's all provided for by the government. It's a good deal. I know a good deal when I see one.
Right. But I also think, like, if just to Nancy's point, which is that, Canada passed its system a long time ago, but I'm pretty sure that wasn't the last healthcare law that Canada has then passed. In other words, you have to start, and you have to start in a way that brings everybody healthcare. And then it is quite possible you're going to learn some things when you do that. And then there remains a legislature who needs to, continue to legislate. And so that we can speculate and we can maybe look to different places in the world and say, well, it looks like this could happen or that could happen with the laws as written. But let me just say that I do think this is a really good bill, and that also you'll never know until you put stuff into place, and then if there's problems, you can make adjustments. So yeah, any other thoughts on that topic, or maybe hit another question? So there's a question that is in the chat, also I think transmitted from Facebook. So, and this is from Elvira Mihalko. And so Elvira, I hope you are out there still, and thank you for your question. And so what she asked, like kind of a political question, which is that now that Newsom has beat the stupid recall, will he sign the bill into law? So that's a question of the mind of the governor. And how about that? I don't think I know anybody better than anybody else. So does anybody else want to say what they think? Speculate? I can give some historical context to that, but anybody? Paul, you got your hand up. What do you think?
Well, several years back, about 3 years back, when he was running for governor originally, I'm a member of another organization called Americans for Democratic Action. And I met his aunt there, and she asked me to give her a ride home. She lives in Westwood. And I asked her if her nephew, Gavin, supported single payer healthcare. And she said, oh, yes, absolutely. So, but that was a couple of years ago. I don't know what's going on now, but that's what I heard. So this is according to her aunt. I mean, to his aunt, Gavin Newsom's aunt.
Well, and he was, it should be said that he was supported specifically in the Democratic primary by the California Nurses Association when he ran for governor, and they also were, took part in recall considerations. I'll see one. I don't know if it's a raise you one. I think it's kind of which is that my son Otis at a Democratic convention, also before the primary, point blank asked him, "Do you support single payer?" And he said, "Yes, I do," to him. Absolutely. And so now he has voiced a kind of different set of views, maybe than other governors, about single payer. He has come from being the mayor of San Francisco, where under his mayorship, they went to not a single payer system, but a universal-ish healthcare system there. And so he's sort of signaled types of support for this. He has political allies in the CNA, the authors of this bill, who I think expect that he will support this. Has he come out publicly in favor of this bill so far? I have not seen that, and I don't know if anybody here has. I'd be interested if they have. His approach, it has seemed, has been this thing of like having the commissions look at the Healthy California for All Commission look at doing single payer in the state. And it seems like he's been quiet, I guess, on the bill itself. So I think there's some context, but what do other people having heard that? What do you think? Anybody?
Well,
I'll jump in.
Yeah.
Of course he'll sign it if it gets to his desk. So every governor, I mean, Jerry Brown famously blocked it from getting to his desk. So will Governor Newsom get Anthony Rendon to block it from coming to his desk? That doesn't seem as likely this time around because it's going through the assembly. I mean, that's Anthony Rendon's house, the Speaker Rendon. So I mean, if he was going to get Speaker Rendon to block the bill again, like he did last time, then it would have been generated in the Senate, and Speaker Rendon would have blocked it, once again when it got to the Assembly. So far, at least, Speaker Rendon even sounds like he's, he could be in favor of it, even. A group of us went to Sacramento when they first opened up California back in June, before Delta slammed us again. We went there to push the governor, kind of before the recall, really got into gear, the recall campaign, or no on the recall. Rendon submitted a statement saying he was on board for single payer, and and the whole position of the legislature as well as the governor himself has been, let's have the commission, the California for All Commission, come up with how we get there, and then we'll move forward with it. It is timed now. The commission has agreed to come up with their report and submit it to the governor at the same time that Oshkosh reintroduces it to go through the committee hearing process. So that is, primed and ready for it to be heard in committee, to be voted on in committee, potentially get through committee, go to the floor of the Assembly, get passed, go to the Senate, do the same thing there, by the end of 2022, and be signed by the governor. Is that a rosy picture? Yeah, of course it is. but who knows? The head of the health committee, Jim Wood, the dentist from Healdsburg, Northern California, is making overture on that committee, saying himself, and those of us who are attending regularly, I don't know, I am an eternal optimist, but it seemed to me most recently Jim Wood said single payer is the only way to save money in the process of getting universal health care to people. I believe I heard him say that. Even those words came out of his mouth. So that is progress. He was, he and Senator Richard Pan, it appeared, were the two who might block this thing. Now, it could still get through the Assembly and be blocked in the Senate this time. That's a possibility still. So, there's lots of negative possibilities too, but I think it absolutely could be signed by the governor by the end of 2022.
And you know, like there's a value to optimism for a number of reasons. And one is that, like, you know, because it helps. In other words, optimism can be part of a kind of movement building and self-fulfilling prophecy, or not self-fulfilling, but a fulfilling of prophecies. And because that's the way, right? Like it has to, because to be passed into law, it has to be signed. This is likely to be the governor at least until the next election. And maybe one way of reading the tea leaves from the recall is maybe for a term after that. And so that is the current route. And so, like that, if you say, well, I don't think he will, then you're just sort of saying, like, well, I guess we're not going to keep trying to do this, but we are going to keep trying to do this because it's the right thing. He knows that too. So go ahead, Bill.
Sorry, yeah, just one more thing on this. So a lot of people, especially from outside California, are trying to, like you said, read the tea leaves on the recall election. What did it actually mean, you know, in terms of Gavin Newsom's leadership? You know, was this just about Texas and Florida and Idaho, how poorly their response has been to COVID compared to ours? Even just abortion rights, for that matter. I mean, you know, California certainly doesn't want to become Texas at this point on abortion rights, you know. So yeah, that may have been it more than anything else. And, you know, Larry Elder, what a nightmare that guy is. But anyhow, if you look at COVID itself and what this governor has done on COVID, okay, was that enough to earn him, you know, the ability to stay in office for the rest of his term? I think that's more or less the referendum. That's, you know, that Californians decided, yes, we don't want to be in the situation that Florida or Idaho is in right now. And that was to a certain degree because of Gavin Newsom. What's the next step for Gavin Newsom? Not just for COVID, but for healthcare in general? It's this. It's AB 1400. So if he can read his own tea leaves and figure that out, then great. He can move forward and show us that he's worth, you know, re-electing and staying in office, because then he's going to push for and put into place a single payer system like AB 1400.
Excellent. So I'm gonna keep going down the scroll of questions. So here's a question, which is, would you donate $5 to Healthcare for All Los Angeles to help us keep working on this? My answer is yes. And I would hope everybody else's answer out there is yes. And there, let's see, that's bit.ly/HCALA donate. So bit.ly HCALA donate. And maybe we could try to put that in pure link form. Okay, so there's the answer to that question. Yes.
I actually put those links in and on Facebook already.
Further down.
Joining.
Thank you. Thank you for doing that. Well, so, okay, here's another question. This is from Chris Shimizo. How would the government process, coordinate payment from health insurance companies of non-residents who need healthcare while visiting California? So that's an interesting question. I am not sure, from my recollection, that the bill answers that. And so, but let me then say something about questions that the bill doesn't answer. Because one of the things the bill does answer is a governance structure for the program. It describes a particular leadership group that is appointed, describes who appoints them, describes some of the characteristics, and some of the, what I would call kind of the executive branch part of putting stuff into play is clearly going to be left up to that group. The bill also describes an advisory group on policy for them and who would be on that. And so that they don't all have to be experts on everything and they can get advice on technical things like that. So that would be my answer to that question. But again, if there's other thoughts out there, anybody else?
I'll just add that, again, a great question for kind of a policy wonk type person, because you've got, you know, who's going to provide the care? How are they going to then, solicit payment for that care? Especially if they're not set up anymore to deal with commercial insurances of any kind, or if they don't do that on a regular basis. Does the state then act as the intermediary somehow? Good question. I think it's, you can look to other, say state, like nation states who do that, like Canada, for example. What happens as an American if you're in Canada and you need care? Oftentimes big systems just absorb those expenses. So if people are, here as tourists or something, they have an accident, the idea is treat them where they lie and then repatriate them, get them back home, where they can incur their own mechanisms for payment at that point. But that may not be possible. So, but the system in California will be massive and will actually probably be able to incur those costs without much difficulty at all. Like everybody's heard those stories. Someone goes to Europe or something, and and you ask, like they get sick, and you go to find out what your bill is, and they say, "Oh, there's no bill for that." They're not a resident. They're and yet somehow the system just absorbed that cost. Why is that? Because the system is so big, it can absorb those those type of costs. Similarly, you have people with it kind of works the same way with people who have horrible medical conditions that nobody could pay for on their own, like who need like kids with congenital heart disease, like the Jimmy Kimmel baby. Who could pay for all that unless you're Jimmy Kimmel, right? So I mean, it's like the system can absorb those expenses. So it's kind of similar in terms of scale. And I remember when I first started working for Kaiser 40 years ago, we didn't have a way to process when people walked in to our Kaiser facilities. We didn't have a way to process them if they didn't have Kaiser. And more or less that was just blown up. Well, over the years, they decided they were losing too much money that way. And then they learned how to bill, other insurances. But when they were in the business of just providing pure, kind of umbrella coverage to people, they just ate those expenses, and it didn't matter in terms of operations at the time.
Right. So I think it's right to say too that these are at some level current problems too. In other words, like anybody traveling out of state, either there's we have like most health insurance is because states do a lot of insurance regulation. Most insurance plans are sort of based in a state, kind of. They're subject to the laws of an individual state. But many insurance plans also, like, most people don't say like, well, I guess I'm not going to go to New York State because my health insurance won't cover me there. In other words, I would just say that this is a current problem or a current question that wouldn't be unique to a single payer system, that a big system is better than a little system in being able to absorb costs, just as Dr. Bill was saying. And so, and I'll also just kind of stick with what I said too, that some nitty gritty if you try to hit every piece of nitty gritty in a bill, it'll be a really long bill. And, you know, having it be core framework, I think, is a virtue. So let me keep going with questions. So I'm not sure if this one was also from Chris, but it's not, doesn't matter too much, which is just the question is valuable no matter what. Maybe it's from Chris. How much in monetary terms do claims cost in time and money to the doctor? And so maybe then what Chris is asking is, under our current system, how big an affair is billing? How much of that, either from a institutional standpoint or from a like a small offices standpoint, how much effort and money and time goes into billing under our current system? In other words, I think she's implicitly saying, like, how big is the thing we might be simplifying if there was only one? So anybody?
I think most private offices claim that they had to hire at least 2 or 3 new people just to process claims. I mean, if there were a couple or 3 doctors. So there's significant hiring necessary.
Yeah. So that's been my experience, is that at least at the office level, that it may be even an hour of work for an hour of medicine or something like that, there's kind of a billing. And, you know, it's shifted some with electronic health record systems. Maybe it's a little different in capitated systems. But also we know that hospitals spend big money on that too. But Dr. Bill, you.
Yeah, that sounds about right. The figure I hear all the time is between 10 and 25% of doctors in their practices of their overhead goes to insurance billing. So that's a lot. I mean, if you have other staff at all, if you have other things that equipment that you use, or rental, leasing, whatever other overhead that you have in your practice. So between 10 and 25% off the top that you can save by not having that kind of insurance billing anymore. So, it's huge.
And let me, go ahead, Dr.
You mentioned electronic medical records. That did not make it easier. In fact, these electronic medical records were devised for the convenience of insurance companies, and they really added to the necessity to have hiring people who could manage those.
Right, and then I think ended up distorting what a medical record is.
Sure.
As not really a document that's about recording the most important things about the person's care, and then having a place to refer to that for the future for anybody who then wants to help that person. But instead they become really tortured by the billing structures. And I think it's hard to estimate just how much wasted time and effort and kind of nonsense it sort of goes into that. But I'll tell a story too that's related to that question. That pretty recently I saw a young man who had moved to the United States from Canada, and we'll just say this: he had I guess we'd say a pretty good health insurance plan. He was seeing me at an office where I take among other things commercial health insurance, and he saw me for he had a rash. I'm a dermatologist for people out there. And so he had a rash and he had a wart. And I came up with a plan and made a prescription to help treat his rash. And I froze the wart that was on his finger. And later on, he complained to our office, to the management of our office, because he ended up, because I had a high deductible, that he ended up getting a bill that he was all responsible for because he had not met his deductible. So he had to pay for all that stuff. Like he had insurance, but he hadn't met his deductible. So he had to pay for it. And he wasn't aware that there would be one charge for me evaluating something and another one for me freezing his wart. And so he sort of was like, Dr. Birnbaum was untransparent and didn't tell me that there was going to be a charge for freezing my wart. And the nature of that conflict, I mean, is one that I think is the kind of stuff created by our system, which is to say that, like, I wasn't trying to rip this guy off. In fact, like, I get paid hourly at that office. I didn't make a dime more because I froze his wart. But one of the things is when somebody comes to the office, I want to take care of their problems and not sit and have a lengthy discussion that's like, what insurance do you have? Have you met your deductible? Are you aware that that for the rash, there'll be one charge, and then for the wart, for a procedure, that there's a different charge? And like, I am sympathetic. And I mean, I think there's, kind of questions of like how the office discloses, blah, blah, blah. But if you really step back and think about this conflict, it's like, there's a kind of madness that's created by our system that doesn't just simply say, why not give people the care they need that they're asking for? Like, he did want help for that wart. He told me about it and said, what can you do about this? And so anyhow, I'll leave that anecdote there. There's a lot, it's like the tiniest tip of an iceberg, enormous iceberg of the things created by our billing system.
I'm going to add a systems anecdote to that anecdote, which is that, I worked in a group model practice, a very large group in the emergency room. It had nothing to do with the billing procedures whatsoever. Whether I performed a procedure or not, like you did, Ron, which I had to do lots of procedures all the time. But what happened over the years with electronic medical records was the burden of billing was shifted from a clerical position to the professionals, to the providers, to doctors, nurses, through the electronic medical record. We're often instructed and, given updates on how to document so that it was clear where the billing codes would be extracted. And that way there wasn't a need for those billing clerks and experts who actually, know that stuff and know what they're doing. And so we, besides having to practice medicine, we were being trained to be billing clerks over the years. And so it's a matter of taking, a highly skilled profession or professionals, and trying to dump more responsibility and, by altering their knowledge base. And do you think you might lose some of your clinical knowledge base in the process by shifting over to becoming, a billing clerk? Of course you would. So, and not to mention Vera's point that you lose time of being able to sit and talk with a patient when you're having to rush to do your electronic charting that makes sure that all of the billing code things get entered before you're rushed off to see the next patient. So you're absolutely right. Although every provider will tell you it needs to be made electronic, so that information systems can be, recorded in perpetuity, not shared indiscriminately, but shared to the point where clinical systems can talk to each other, which is part of the problem that we have right now, because insurance companies don't allow that to happen for proprietary reasons. So that's the good, bad, and ugly of electronic medical records from my perspective, 2 years of practice. Thanks.
Super. No, there are there's a lot of like kind of comments also in the chat, and I might not be able to give them all their due. And so I'll keep kind of emphasizing questions. There's a lot, there are a fair number of kind of political questions. So I saw both Paul had passed from James, which rank and file healthcare workers are most opposed to CalCare? Lynn asks, anybody know if billionaire Reed Hastings supports AB 1400? I guess you certainly oppose the recall. We know that.
Ignore my questions. They're political comments more than questions, so you can ignore them.
Got it. Well, and they're welcome. So I'll keep looking. Let's see. 70%. Do you have it? Okay, I think this is a question. Let's see, question, because this looks like a question because it starts with the word question. Question, 70% of Americans support Medicare for all, or at least Medicare for every American. And AB 1400 is essentially Medicare for all in California. So you do have any ideas about what we should be doing to get that supermajority of 70% organized and mobilized to effectively demand of our representatives the passage and implementation of CalCare? Well, I guess I would say then it's a healthcare organizing question. So I'm going to say I don't think I know better than other people, but let me throw it out there and just see if anybody has thoughts about that, because maybe somebody has a better idea than me.
What we're doing right now.
Well, and so it's educating, right? And like why it's one. So thank you for saying that, actually, because in a sense you're right, which is I don't know, like sometimes political stuff is framed as fighting, and maybe more of our political stuff should be framed as educating. That if people really knew and understood, and we know we can't reach with this Zoom and the people out there in Facebook land, we know we can't reach like everybody, but we're hoping that more knowledgeable people talk to more people, and that this is a contribution to that effort, certainly. But will that mobilize 70% of the people? I will also leave that to others to speculate, and keep looking for questions.
I had can I say something?
No, go ahead.
I had a conversation with a longtime friend neonatologist in a community hospital this afternoon about this very topic. And my opinion is that the elephant in the room, one of the elephants in the room, is that proceduralists and surgeons are not on board. And I think they do an awful lot of biasing the public against single payer. And I think, I've heard the details addressing that at this meeting, and I think more effort has to be put in that these big income proceduralists are not likely to suffer very much as they are implying to people. And that it's always impressed me that most of the doctors on these kinds of calls are pediatricians and general practitioners, more than proceduralists.
Though there are exceptions.
Yes, you are a wonderful exception.
Yeah, but okay. So then what you're saying is there needs, at least to the extent that procedural specialists wield some political power or influence over the legislature, the public's opinions, that there needs to be more of a, maybe a direct kind of physician to physician communication and educating people and sharing and dispelling myths. And, you know, that's certainly, I would say, one avenue of the organization Physicians for a National Health Program. I also am of the opinion that that's maybe an important activity and one I've tried to participate some in, but that it's also probably not sufficient, but maybe necessary. So whether it's an elephant or one of many, or maybe one of a troop of elephants.
But it's not only that they carry a certain amount of influence, they disproportionately carry a large percentage of the overall income that physicians make. And so they wield financial power over the medical system as well.
So that is an interesting question that we have, I think, speculated about a little bit in the past, in some past office hours. And that is, we do have a system that probably it does reward procedural services more than so-called cognitive services. So that's often the way it's described. And would that change in a single payer system? So maybe I'll throw that question out there as a kind of version of that question, because maybe it's implicit in that, is that you're saying the procedures are saying we're going to make less, we're opposed to it. And so we're opposed to it. What do you think, Dr. Phil?
I'm going to take a little different tack here and kind of go back to Isaac's original question, which was, if 70% of the public overall likes the idea of this, how do we organize and mobilize people? And just to, to cover what you and Nancy were talking about, at least before we get into the bigger subject of organizing and mobilizing, is traditionally the medical community had a lot more power. It certainly is still respected to some extent, but it had more power politically than it has now. And now the big power players are the ones that we all know. They have to do with corporate elites, big banking, which is tied in with big insurance, U.S. Chamber of Commerce, big pharma, big hospitals, big group medical practices. And then we can get into, kind of like the smaller, subdivisions of medical practice kind of thing. So of those, let's just say insurance, pharma, hospitals, providers, it's really what we need is that 70% of people to go after the giants. Because if we don't go after the giants, which in my opinion, the two really big giants are big insurance and big pharma, maybe big hospital, you could throw that in too, okay? And more providers are on board with us, doesn't matter what specialty you're in. Frankly, if you're a surgical provider or not, you could see as much threat to your ability to practice medicine from big insurance, big pharma, and big hospitals. And so for those of us who understand that about the system as it is, it's really a question of organizing, mobilizing everybody else. And that's why what this is that we're doing right now is so important, because it's not just a question of education, it's discussion. It's the questions that are being asked are probably more important than the answers that are being given. And that's to look at all of these, these things that circle the issue, and to engage as many people as we can in these discussions. And then that's going to do what Lynn brings up in the chat, which is how then do we influence those people in position of power, our 80 assembly members and 40 state senators? And the way that's done is by these community discussions that then translate into electoral politics, where we can either support those people in office who are willing to do these things, or replace them with people who will if they won't. And so I think that's what we need to be looking at to mobilize that 70% and make these things happen.
What a wonderful answer to that question. Thank you for that. And let me just keep going down some questions. There's been good ones today, great questions. So Betty Faye Dumas, Betty, who I assume is also out in Facebook land, because I don't see her on the list here, but another incredibly dedicated activist who's given blood, sweat, and tears in gallons full to trying to move our state and our country to do single payer, asked the following question: what are some of the provisions to build equity in our healthcare system built into AB 1400? And I know she's not talking about like shareholder equity. She's talking about like things being equal between people. And so that maybe starts with the question of what are some of the things that are unequal about our current system? And then how would a single payer bill address those? And I guess you could also ask the question, which you didn't ask, which is, are there things that it wouldn't or couldn't address? But let's start with directly her question. What are some of the things in the bill that would make healthcare more equitable in the state of California? Anybody? And you don't have to be an MD to answer this question. I just really want to stress that, because I think there's plenty of the people who've been here have, although I welcome everybody's answers, have been swimming in, maybe not everybody, but what are some just maybe one, like I said, one of our non-MDs.
Someone needs to channel their inner Gina Harris to answer this question.
Yeah.
Because Gina would just like take off on the 7 basic principles of CalCare at this point, because I think there's something in every basic principle that has to do with equity. You know, there's freedom, there's fairness, there's universality, you talk about it, you know, like every aspect of the 7 basic principles has to do with equity. So nowadays I'm looking at this as healthcare reform has to mean 2 things. You know, it's like I remember when the concept of Medicareforall came up, you know, expanded and improved Medicare, and it has to be for all. The for all part is equity, right? But it has to be expanded and improved, which means it's got to be quality and equity, not just equity, not just quality. It's got to be both. It's got to be quality and equity. And so, you know, what is it about CalCare that ensures quality and equity? Every freaking one of them 7 principles.
Yeah, no, I absolutely agree. Have all kinds of thoughts myself, but I don't like people who have been, you know, wading in these waters for a while. What, anybody? I'll say something. I think that one couple aspects of the bill. So yes, it turns out that having health insurance, the absence of health insurance is associated with illness and death. And so we have inequity between people who have any kind of health insurance and those who don't have any. We also have inequity between people who have health insurance products that aren't very good and people who have better. And so those are, and those inequities map across the usual suspects inequities in our society, socioeconomic and racial inequities, no question. Another big area of inequity that I think is directly, and that's sort of like, I would say, true of all universal healthcare type single payer bills, right? That they aim to solve that problem, and this one would be no exception. But one of the areas where there's been historic inequity is that when you have a system where capital investments in healthcare, buildings, equipment, machines to do diagnostics, are distributed based on where profit is most available, well, guess what? Those things don't end up being as accessible or available in poor communities. And in California and in many parts of this country, poor communities also often means immigrant communities and communities of color. And so the bill directly takes those on in that it has both just kind of capital budgeting done through state mechanisms, number one, and then it also has a special projects budget really meant specifically to address those kinds of inequities. Sorry about the dog. So there's a couple answers there. Let's keep going.
Well,
Go ahead.
So because you didn't pick up on my prompt, but if I can just share the 7 principles one more time.
Sure, Mommy, I can put that up.
I got it.
Oh, you got it, okay.
I got it. You kidding? I live by this too. So just real quick, I'm not going to go through it like you did, because you actually did a great job and in exhaustive detail. But I just want to add to Betty's prompt, because she did tee this up for us, that a few things. Universal means everybody, okay? So regardless of race, gender, sex, or country of origin, disability status. I mean, you might think that's enough right there in terms of equity, but actually there's more, because decisions being made should not be based on commercial, as you said, commercial interests or market interests, which they are now. So healthcare is being marketed, and that means regional differences as well. A single public program that eliminates waste, not just waste, but also fraud and abuse, okay? Because it's transparent. When it's done behind closed doors by commercial entities, we don't know the backroom deal. That then prompts inequity. That then, promotes commercial and market interests, not human needs. So that's an important aspect of this. The fact that it's fully comprehensive, meaning everybody gets all of these services, that means equity as well, because it's across the board. It's everybody. You have complete freedom of choice. That means that you are free to go. I mean, obviously, it's going to be within your capacity. If you live in, Chico, California, it's not going to be easy for you to travel down to UCLA Medical Center or Scripps or something like that. But you will, within whatever means you are capable, be able to go to any provider that you can. So those regional differences, we're going to have a board that's going to help you in any way that it can for you to get those services that you need. So that's also equity, and it covers regional aspects too. Free at the point of service is equity as well, because there's no financial impediments to block you, from from going or not to see a doctor. That's huge. I mean, how much of that is why we're performing so poorly in this country under COVID and the pandemic. It's huge. Even the just transition out of bad medical jobs into good medical jobs or other jobs, outside of healthcare is also equity. The CalCare will train people and make sure those people get into better work situations. That's equity as well. And finally, care based on patient need. This is something Joe Biden said the other day. Actually, was in reference to big pharma. He said, if the days where they could price healthcare and pharmaceuticals based on market interest are over, they're going to have to start basing their pricing for healthcare on human needs instead of what the market will allow. That's what this bill does as well. That's equity too. So, sorry, but I think we weren't doing the question a service if we didn't cover kind of all of those aspects, at least, to a certain degree. Thanks.
Completely agree. It's really one of the truly underlying themes, I would say, of what makes single payer, but also what makes this bill what it is. I had seen Lynn Harvey, your hand was up.
Yeah.
Did you want to pick up?
Yeah, let me lower. I actually had a question on that last item, the patient care based on patient need. It seemed kind of vague to me as far as a bill and subject to interpretation or misinterpretation. Just wondering if you could elaborate a bit with more specific information, or what does that really look like in real life?
Sure. And I think I can say what both the bill writers, how they put that into law, into the language, and why whoever did this graphic, having and I can put it up too, why they put that and why they put the text underneath it, right? So the implication to saying, well, okay, under this bill, patient care is going to be based on patient need, is that currently not all patient care is based on patient need. And so what that speaks to is that there are financial incentives in both our healthcare system and in a lot of healthcare reform proposals that may not, in fact, focus patient care based on patient need. So, for example, the bill does prohibit essentially capitation agreements. So, or capitation, which is where a provider takes a bunch of money, a provider, institutional, or even in theory, an individual, to provide care for a big group of people, for a set group of people, an identified set of heads. In this case, capitation means that set of heads. And so what's wrong with that? Well, that provider might have the incentive to provide less care or not do things that were needed or necessary for those individuals, if that provider was going to keep more of the money by not doing that, right? So that's been one model out there for saving money in the healthcare system. So that's one. So then another has been people saying things like, well, we really should be paying for outcomes, or for not just that some procedure gets done, but how successful something is, or how good a primary care doctor is at making sure that everybody in her practice has, normal blood sugar and doesn't have, is getting, that's getting checked, and they don't have diabetes. And a lot of that stuff sounds pretty good, but it turns out that there's a lot of, when you kind of, look under the hood at a lot of schemes for payments of institutions and providers, that they can end up leading to care that's provided, or care that is or isn't provided, not based on patient need, but based on meeting some numbers or some profit target or other stuff. So that's what that is. And there are specific things in the bill that prohibit essentially value-based payment, capitation, and some other schemes. So I got you that that thing looks kind of like a general statement, but it's actually tied to some very specific language in the bill that kind of dictates how payments happen under CalCare.
Does it mean, like, I've heard cases where doctors will order a bunch of tests and that don't really need to be done in order to make some money off of the tests? Would that be a case of that?
Well, it could be, although, those are also issues where, there's some like kind of ethical issues related to like self-referral, like things where you order a test for somebody, but you are the doer of the test. And so that, I would say, is not something that's very specifically addressed in the bill. And so another way of answering that question is like, what are the main payment structures that are in the bill? So to be very succinct about it, it envisions what are called global budgets for institutions. So a big hospital would get like one big budget for the year, as opposed to being paid for each little piece of work that it does. But physicians and healthcare providers in offices would be paid still through a fee-for-service mechanism. Now that has been criticized as potentially making people want to do too much, provide care that isn't needed because of doing too much. But over the years, a lot of the thinkers in the single payer field have felt that while that may be true, that there could be in fee-for-service systems, there may be some incentives that are not perfect, that they are the least bad incentives, that the biggest, baddest incentives may come from people finding ways to restrict care or prevent people from getting care to make money. And so I think that's a pretty good accounting for what's in the bill and some of the things that the bill says that you couldn't do in California. So let me take that share down.
I would just add to that, and Helene, it's a terrific question. Some of that exists, of course, now in systems that are set up, even single payer systems like Medicare and Medi-Cal, which is, of course, Medicaid across the rest of the country. There are administrative boards that monitor that, and to make sure, however and whenever possible, that kind of over ordering does not occur. Fraud, in this case, in the case where it's frankly, fraud or criminal even, that it could be prosecuted. So, or referred to the Justice Department for prosecution. That at least you have the potential of taking action. It's actionable in a public system. In commercial systems, we have no, the public has no way of taking action on those things. So if that's going on, and I would submit to you, it's going on a whole lot in commercial systems that we're not aware of, the kind of over ordering of tests and procedures and all that stuff is going on in commercial systems. And we as the public have no control over it. It's all done by the invisible hand of the free market system, quote unquote. And that is one of the things that's caused runaway, out of control prices in healthcare. So the other thing I would bring up that I like to bring up, sorry, I think those who come to these meetings a lot, as Paul knows, since he hosts them all, know that I'm fond of bringing up is over ordering due to what we call defensive medicine, which is medical malpractice, not fraud in the case that they're ordering unnecessary tests as much as they're ordering tests because they're afraid someone's going to think that if they didn't order the test, it was malpractice, or ordering treatments or antibiotics, whatever it is that you can imagine, because they're afraid they're going to get sued if they don't. In single-payer countries, you lose a whole lot of that incentive for malpractice suits. And that's because the doctors actually re-earn the trust of their patients because there's no disincentive to see them anymore. You have open access to see your doctor. You can actually have a relationship, a doctor-patient relationship or provider-patient relationship again. And you kind of establish or reestablish trust, and you're not going to sue the person that you trust, who's open to you and that you can go to with questions, and they take the time to answer your questions to the best of their ability. They also lose incentive to sue because there's no bill for what it was that they came to you for. So, single-payer countries have about half of the malpractice, have half the defensive medicine, have half of the over ordering that we have in this country. And that in and of itself is going to lower prices, lower costs, substantially, and make it much easier and better, for practitioner and patients alike in the system.
So I think that I don't think I see any outstanding questions in the chat, which doesn't mean we can't raise more questions. But I don't see. Well, okay. Here's one. Maybe I kind of went over. So I'll take it back. So there was a question. This was at 5:58 p.m. So I don't know if Elvirus, you're still out there. So Yuhus, and this is kind of related to, I guess, incentives and that kind of thing. So Yuhus, so would doctors and medical providers be able to spend more time with their patients instead of rushing them through to meet insurance quota when we get healthcare for all? And so I think that it is related to the discussion that we just had. And that's that, well, why, or you could say this, why is it that it sometimes seems like there's like really short visits available at doctors' offices? And actually, I think that those can be problems in a lot of different corners of our system. And so one would be that if you have fee-for-service healthcare and people are billing not based on the time that they spend with people, but based on the another dog event. Not based on time, but based on sort of how complicated the thing they discuss is with the person, then and how much they sort of evaluate, then that there could still be some incentives in some places for people to want to see a lot of patients. So then another issue that's out there, some incentives in some places Oh, it's getting feedback from from Facebook. So hello, Ron Birnbaum on Facebook. So another part of that story might be that you have one of the problems in our system too is that in some places, in some corners of the system, some payers pay very little. So for example, Medi-Cal pays physicians, particularly specialists in the outpatient setting, and some very little money. So that creates a set of problems, which is one is that there are not very many doctors who want to see those patients. And so there end up being shortages, but those shortages of availability are inequitably distributed, getting back to our equity question, so that people who are poor face those inequities more. And then some of the people who try to address those will say, well, we just these are the specialists we have. And so we need to try to, if we're not going to have incredibly long wait times for people to come in, we're going to try to just help a lot of people quickly. We're going to do our best to help a lot of people quickly. So I don't know that single payer solves every issue of whether there's a doctor spends enough time with a patient, but I do think it would solve a big chunk of those issues. It would also show us better where we have shortages too, because one of the problems we have right now is that shortages are felt inequitably in our system, and the least empowered folks in our state bear the brunt of the shortages of all kinds of providers, especially including primary care providers. And so that then sometimes I think saps some of the political will to solve those problems, because if the people making the decisions aren't facing the shortages, but they may not be as aware of those problems. So there's a question. And then did my answer to that? I don't know. Did anybody have other questions? Do we have some new ones?
I'm going to jump in, so Ron, on what you just said. And if folks haven't seen the wonderful old film, it's old by now, but I know a lot of folks were looking back at the early 2000s, looking at 9/11, Sicko. There was a great movie around then that came out called Sick Around the World that was done by a journalist by the name of P.R. Reed. And he did that for PBS in their Frontline documentary series. He also wrote a book called The Healing of America, which is on the same subject, meaning what could he learn, what he learned by kind of traveling around the world, examining health systems, and applying those learnings to what our problems are in the United States healthcare. So it's either the video, Sick Around the World, or the book, Healing of America, by T.R. Reed. I think it's spelled R-E-I-D. But T.R. has this wonderful couple of, like video sequences in the movie where he interviews people involved in healthcare in these different countries. There's one great scene that he interviews a primary care physician in Japan. And I think I've talked about this before, but as we know, in Japan, so it's not the length of time they spend with their patients, it's the rapidity in which they see patients. They see them very frequently, especially they're elderly, and they have a much, much higher life expectancy in Japan because they really take care, they highly prioritize healthcare for their elderly, and great respect for old people, for seniors in Japan. And apparently we don't here. We don't care about our elderly. We don't care about our kids, right? Like we underpay our teachers and our pediatricians, and we don't care about our elderly either. We want them to disappear. In Japan, they see their doctors on average 13 times a year compared to our 4 times a year. 13 times a year. Now that's on average. So most Japanese are not seeing their doctor for 13 times a year. Who is mostly? The elderly. And how many times are they seeing their doctor throughout the year? Probably once a week, right? So in this little video sequence that Tia read in Japan, an elderly woman comes in to see her doctor in Japan, and they have a conversation. He takes her blood pressure. He reads something on the screen. She asks him a question. He answers her question, and she goes home. And Tia Reid, he lived in Tokyo for like 6 years. He's an older white, middle-aged white guy, but he speaks fluent Japanese. And he says, "Is that it?" He said, I know what you said just now. He said, "I don't see how she could be happy with just 5 minutes with you. And, you know, that's not enough time to spend with your doctor." And the doctor looks at Tia Reid. He seems confused. He goes, "Oh, wait a minute. You don't understand. She's here every week. Every week, you know, Tuesday at 3 p.m., the woman comes in and sees her doctor. It could be only for 5 minutes. And maybe she just has one question to ask. And maybe she's just getting her blood pressure checked and he's making sure she's taking her medicines right. But that's a relationship. She sees him every week. We don't do that in this country. We don't have that kind of relationship. We don't treat our doctors like they're part of our daily or weekly lives. And that's what we need to do. We need to look at it that way, that to change the whole culture of our healthcare to one, you know, that's more supportive. And I'm just going to throw out one more thing. Sorry if I'm taking up too much time here, but I think we have a little time still. But this idea of medical misinformation right now that's out there with COVID and people taking horse dewormer and, you know, gargling with betadine. I did not recommend that, by the way. but all this medical information people are getting on the internet, why are they taking it seriously? Because it's unbalanced by trustworthy medical information that they should be getting from a doctor or a medical provider, a primary care provider. We don't have that. We're out of balance in this country. You don't have a trustworthy information source that you can go to in this country. So you're going to go to all this crap that you hear from other sources. And that's something that they have in Japan and Taiwan and Germany and Canada and France, even in Cuba, where they prioritize primary care that way, and that we can do in California if we pass this AB 1400 and Medicareforall across the country. Thanks.
Yeah, you know, what you just said was making me think about something, which is that, you know, one of the focuses of office hours has been like, what is in this bill, so that we can share with people like what, you know, the bill actually says and what it will do. And yet, like, it really is the case that there's a lot of power in the white space of the bill, like where the words aren't. But which is to say that if you build a system where everybody is in and where everybody has access and where the decisions are made based on need, that you open to a whole set of possibilities that don't even need to be written down, but that are what would happen if things were kind of unconstrained by some of the constraints that are in our current terrible system, right? Like they're not written out, you know, but you could start to, you can look around the world and imagine, like, what if we had those kinds of, like, such a better structure here? What would the human beings who do the good work fill in between, in there. And that it fires the imagination, and it's the stuff like that that keeps us working on, I think on these issues and then on this issue over time. You just know it could be so much better. And then you even know you don't know how much better it could be, right? Like there's a lot of ingenuity and love out there, and we do actually, we train great nurses in the United States. We train great doctors in the United States. There's a bunch of really good aspects to our system. We have like access to research capacity in our universities, unlike, a lot of other places in the world. But like, we get such bad results given those things, given the human strengths that are in place in our system. It's just like, the more you think about it, like, why would you put up with a system like this that sort of constrains so much? So, that's one of the reasons why we do this every, Sunday.
And people think it's inherently, the politics, or it's the nature of us and our culture, and they're just willing to blow it off and say, oh, we'll never figure this thing out. But no, it's not true. It's a systems problem. And we have a system that needs reform. We have a system that needs fixing. It's a broken system, or it's no system at all. It needs a structure built. That's what this does. It builds the structure that we need. And we don't have to, accept ourselves as deficient somehow. Americans are just deficient. It's like Canadians going, what the hell's wrong with you guys? It's like, oh yeah, we're just the ugly Americans. No, we don't have to be this way. And that's what this fight is all about. It's that realization. Does not have to be this way.
I agree. I see, let's see, there's more questions. We have, I think, time for a few more. There are a couple that are more about kind of political process and organizing, which are important, but let me circle back to them. There was one that just came from Jim through via Paul. And Paul, thank you again for all that you do and have done to really sustain this effort and to coordinate the Zoom and the Facebook. And like, even when your niece is getting an Emmy, you're still on here. It's amazing. So congratulations to your niece. I saw that in the chat, by the way. But you transmitted this from James. So he said, how would sports teams, physicians, et cetera, be classified? Presumably the sports stuff will be covered by the team. Could there be some waiver so they can work in CalCare too, or will they have a 2-year exclusion? So as I am an avid soccer fan. I have season tickets to LA Galaxy. So this is like a question I've not even begun to consider, but I'm like, it's sort of interesting exercise to think about, like, how would the bill deal with sort of maybe kind of special types of healthcare for special populations? And so, it is, I think that the bill would still, because somebody could, I think there would be some people out there taking the 2-year exclusion and being the sports physician for the Lakers, the doc for the Lakers or whatever. I think that there are people who would operate under some different structures like that, and the bill allows for that. But sports medicine is also it's a covered, benefit in a lot of settings. A lot of it is just a combination of kind of occupational and orthopedics and some other types of care that I think mostly would just fall under the very generous benefits that would be defined. by this, that it wouldn't. So I think that's the answer to that question, which is that you might still have kind of like special little jobs out there that are healthcare jobs that really do kind of fall outside of the system. And then also that the system would also take care of a lot of people, because it turns out that, like, you know, the AYSO soccer team that my kid plays on, well, like, people get injured there too. And not everybody has health insurance, you know, and people get injured playing for the LA Galaxy, and they get injured playing for Los Feliz, you know, girls team 3. And all of those folks need to be able to see somebody to get help when they need it. And this bill would make that the case, no question. So I see a couple questions, one from Chris and one from Isaac, who's here. Let me.
There's one, Ron.
Yeah.
And that question that Jim, I guess, asked about sports medicine, it does kind of interface with workers' comp too. So I mean, any kind of job-related healthcare issues, whether you have a physician assigned as an advisor, you know, to that that work-related you know, condition or not, and could be as an employee or not, or a subcontractor. The healthcare part of it, you know, could be provided under CalCare, I think. But you know, it would undoubtedly, the board would you know, have established. I don't think it's covered in the language of AB 1400 specifically, but I'm sure the board would you know, qualify providers to do that kind of work. The fact is that once you have universal health care, all of the medical liability for employers, for, you know, insurances like, say, property insurance, car insurance, all of those medical liabilities are gone. They're eliminated because you have universal health care. You no longer need special provisions for medical liability in any other setting. You have universal coverage for medical conditions. So, so that means there doesn't have to be a workers' compensation for medical coverage anymore. But there does need to be workers' compensation for lost wages and, you know, things like that the employers are also liable for. But in terms of, you know, practices, medical practices related to an employer's or employment situation, say with a hired employee or contractor as the medical provider or consultant, I think that is something the board would, you know, have a policy related to.
Yes. And anything where there's liability that involves healthcare as part of it would go away, because you don't need to, you're already eligible for healthcare. It doesn't matter if you're injured or not. You're already eligible because you're a human being, which is the only thing that really counts, should count. It's not the only thing that counts in our current system.
That's called skin in the game, when you have actual skin.
Yes. Yes.
In your specialty.
Yes. So, we're not going to hit everything. Let me mention, because Isaac, you're here, and I see a question that you asked. It's sort of a meta question, which is, how can we measure the effectiveness of groups promoting single payer? What metrics do PNHP or HCA use to determine how well they're doing and decide how they can do better? And so it's an interesting question. It's a little bit of field from the office hours aim, but I mean, what I will say is, in kind of closing, that this weekly office hours thing is an activity of Healthcare for All Los Angeles and PNHP California, PNHP SoCal. But those organizations in this state, as far as I know, are 100% volunteers. I don't think any of them has anybody on their sort of like meaningfully on a regular payroll or anything. So does that mean organizations should be self-reflective and ask themselves, how can they do better? No, it doesn't. But I think the answer is that these organizations haven't asked those questions. They've just tried to come up with ideas and do their best. And ultimately, it's not just the advocacy organizations that will make this happen. It has to be the public. So we hope that we're educating the public and motivating the public. I'm sure that's not really a satisfactory answer to your question or like what you're hoping for, but that's all I have at least to say on that right at the moment. So you want to close this? Go ahead, Isaac, because you're speaking or asking about what more can we do, and that's a good question. Like, what more can we do? What more do you think we should do? How about that? And let's end with that. Go ahead, shoot.
Oh, thanks, Dr. Birnbaum. The two things that strike me as the best internal ways to measure our effectiveness would be, number one, how many people do we have on our list of supporters? And number two, what percentage of those people are we able to mobilize to take an action that might help? Like, for example, calling their representative. Although calling their representative, if we only get 5 people doing it, is not going to be that effective. So there are probably other structured tests that we could do prior to, so that we can get to a place where we have a number of people that makes us proud taking an action, and then start getting them mobilized, targeting their representatives. So the two measures, I would think, how many people do we have, number one, and number two, how many of those can we get to do the action that we believe will help?
They're excellent points. Ones that also can be brought up in the steering committee type meetings of those organizations, and should. Let's end here on that note of how can we do better, because this in fact does matter. It's not just for fun. It's not a hobby. It is to do better in a state where we haven't done well enough. It's to do better in a country where we've tragically failed for a long time. And so it's a good place for us to end. We will see you all next week. I want to again thank everybody who's on Facebook, thank everybody who's here with us on Zoom, and we'll see you next week.
See you next week. Thank you, Dr. Birnbaum, Dr. Bill, Dr. Naparko, and Isaac. We'll see you next week.
Yeah.
Thank you,
and
Paul.
those who were here earlier and had to bug out.
Thanks, Ron. Great to have you back, Nancy and Isaac. Great to have you with us, as always.
Good to be back.
Bye-bye now.
All right. Good night.
You guys.